Yes, so nice to be here. We'll be talking today about psychiatric consultation and CoCM. My background, I'm a general psychiatrist by licensure with additional training and expertise in a wide spectrum of different integrated care models. I work as a national medical co-director for Collaborative Family Healthcare Association, in addition to working with MHA. And then I also work clinically as a integrated care consulting psychiatrist for collaborative care, as well as primary care behavioral health models of care. This is time for you guys. So really want to make this interactive. I know not everybody can come off camera, but as we have questions sprinkled throughout, if you want to put them in the chat, come off mute, this is the time to do so. I know there can often be questions about psychiatric consultation if you're working in collaborative care. So that brings us to our first question. Go ahead and put in the chat or come off mute. What is the role of the psychiatric consultant or the PC on the collaborative care team?
I mostly have my camera off because I'm going to eat lunch and it's salad and it's not pretty. But I'm saying I'm a child psychiatrist we've just started implementing this. So I think like how I'm conceptualizing of it right now is really to provide sort of like support to the pediatrician and to the care manager and help view it as like helping the pediatricians feel more comfortable doing some of these evidence first and second line things where they know that they can phone a friend easily, and that like if it doesn't go how we're hoping, that they kind of give them that confidence that they can do it, and that it's kind of just helping provide that advice and recommendations and support.
Beautiful, thanks. Is it Dr. Jacoby?
Yeah, but Selena, please.
Okay, you know, you're spot on. So it's a little bit different than the traditional psychiatrist role. And so our job as psychiatric consultants is not just to that of the patient, right? It's also to serve the overall care team. And really that's the power in this role in collaborative care. So you've seen some of these basics before, but I want to kind of lay them out with the framework of where the psychiatric consultant sits. So keep in mind with the collaborative care team, everything is really built off of this patient-centered care plan with a team-based approach. And we have our primary care provider that's really the team lead, helping to establish the care plan with the patient and getting input from other team members, but all of the care is really incident to the care that the primary care provider is offering the patient. The behavioral health care manager is going to have the most direct relationship with the patient, as well as the PCP, gathering information, communicating with both, and really serving as a central liaison. And then we have our psychiatric consultant. And so they're going to work most directly with that behavioral health care manager, but are going to have these indirect ties to the PCP as well as the patient. Occasionally, they may be seeing the patient for a direct eval if that answer or that clinical question can't be answered by the information gathered from behavioral health care manager and the PCP. And they may also be consulting directly with the primary care provider, but often that consultation is going to happen through the behavioral health care manager. One of the major tools that the psychiatric consultant has to help with communication and help with organizing the care is going to be through the registry. And that's really going to help to facilitate one of the other core components of collaborative care, in addition to the patient-centered care team, which is measurement-based treatment to target. And then as part of the goal, the psychiatric consultant is going to really help to make sure that evidence-based care is being delivered, both in terms of treatment recommendations for medications, as well as behavioral recommendations that they're making to the behavioral health care manager. They're not consulting on everybody. They're really consulting on the patients where there's a clinical question at hand and a care need, which is different from a traditional psychiatrist who's going to be having care directly for all the patients. This is a population-based care approach as such. So we're really looking to how can we best serve the needs for the overall population, not just one individual patient. And this is accountable care. And so this isn't a derogatory term of like, we're going to be making sure that you're doing what you're supposed to do. It's this idea that all of us are part of the same care team and we're all responsible for making sure the population as well as the patient gets better. When we look at kind of the core pieces of the definition of a psychiatric consultant, and this is coming out of Medicare guidelines from CMS, as well as from the CPT manual from the American Medical Association, there's two main components. And the first is the psychiatric consultant is a medical professional. So with that, they are trained in psychiatry. They have specialization in that area, and they are qualified to prescribe the full range of medications. There's been questions about, do you have to be a psychiatrist, or can psych nurse practitioners do this, or can psych PAs do this? Look at this definition, so is the professional qualified to prescribe the full range of medications? And that may vary state by state. That may also vary with like physician assistants are really having to prescribe under a physician. And with the training in psychiatry, what does that look like? That's not spelled out and defined in these criteria, but you want to make sure that whoever is doing the consulting is really able to have greater expertise than the individuals they're consulting to. It's not really helpful if the recommendations meet exactly what the understanding already is. We really want to be able to offer pieces that allow for those we're consulting with to practice to the top of their scope. And it's also a defined care role. And this is different from traditional psychiatrists in that they expand psychiatric care across the entire population, just like Selena was sharing. And they prioritize monitoring and consultative supports. Again, supports through indirect care interventions, different than taking over the treatment relationship. In terms of the spectrum of psychiatric consultation, there's not just one area. It's really a collection of different consultative techniques and interventions they can prescribe to they can provide to a population. And so it's helpful to think about these in terms of the amount and intensity of resources, as well as correlated with that, the amount of liability with each patient. So at the lower end, we have no consultation at all, which is no resources are used at all. There's no liability in terms of that direct patient-doctor relationship, all the way up to a full treatment relationship, where the psychiatrist or the psychiatric consultant is the one with treatment authority for the patient. At the lowest level, we have curbside consultation. This does not have a billing modality for collaborative care, but it is incredibly important for increasing uptake of collaborative care. What we see is that the more engaged our primary care population is in getting curbsides and reaching out to the psychiatric consultant, the more likely they are to recommend patients to collaborative care, the more likely they are to trust the recommendations for the consulting psychiatrist. So this is a really, really important part. These are question-specific, not patient-specific consultations. So the psychiatric consultant is really looking for a clinical question to help clarify, how do I manage this side effect? If I'm trying to decide between two diagnoses, how do I approach that? It's a clinical question. So although it is helping in the care maybe of an individual patient that this is arising out of, it is not a patient-specific consultation. So there's no documentation in the electronic health record. This is for edification, educational purposes. That being said, when these are done well, they're done in real time, 90 seconds to maybe 3 or 4 minutes, and they can be really helpful for PCPs who learn how to use them well, solving for stuck points. We then have electronic monitoring, which is what we do with the registry, where we're looking at a whole population and looking at where kind of different people lie on that. And that in turn helps to go hand in hand with identifying electronic case reviews. And that at the highest end, this is direct eval. So this is like what we do with consult liaison psychiatry in the hospital. We're doing face-to-face assessment. This is the highest level of resources. This is where there's also that question of, it can be confusing of where the patient-doctor relationship is. So making sure there's really clear disclaimers about who's maintaining treatment authority, and you've got that as part of the informed consent. So on the lower level, PCPs are the ones really engaged in terms of that collaborative care relationship from that first slide, whereas the patient is really the one engaged for the direct eval. And where we're going to have most of our activities in collaborative care are going to be those through the BHCM. So that's going to be your electronic monitoring, particularly with the registry, and your electronic case reviews. Keep in mind, for billing and coding purposes, billable collaborative care time in CoCM comes through those care manager discussions. So think about that as you're structuring the different levels of consultation. So for instance, if you're going to do a direct eval, it would be important to have a different billing and coding piece if you are going to be just working with the patient. But let's say you join a care manager touch point with the patient. That could be then bundled under collaborative care minutes. So we think about this for both clinical purposes, administrative purposes, as well as risk and liability. A lot of the discomfort for psychiatric consultants comes from not understanding these key principles. So if you're feeling uncomfortable by a certain consultation, modality, or incident, try and bring it back to them. That can help to direct where to go next and also sort of where the scope of your role is and where it isn't. So I've got another question. Feel free to come off mute. Feel free to put things into the chat. It's okay if you don't have to come off camera. I know people are eating and doing other things. That's okay. So our next question is, how is the role of the CoCM CP different from a traditional psychiatric specialist?
So I'm not 100% sure, except for I believe, with the CoCM, it's rare for the psychiatrist to actually interact with the patient directly. They're mostly coordinating with the behavioral health specialist and then even sometimes the PCP, but mostly that behavioral health specialist is kind of the piece that holds all the other pieces together. Is that?
That's spot on. That's beautiful. And isn't that a little bit different, right? It might take a different skill set. It might be a little bit uncomfortable, especially if we've been trained with traditional psychiatry. So how can we see the patient through the eyes of another person? That can be kind of scary. What do we need in terms of the minimum need to know from our care manager? How can we make sure they're gathering that key information? You're spot on. Any other answers? Any other thoughts? All right, that's perfect segue into what we're talking about next. So keep in mind that with a traditional psychiatrist, the role is really centered around the direct patient relationship with the patient. What you are seeing directly from the patient, the information you're gathering directly from the patient. There may be collateral that's gathered as part of that, but really your relationship with the patient is what's driving the treatment planning and driving the assessment. Versus in collaborative care, we're really looking at patient through the lens of the population approach. So we have our care manager that's gathering information about all the different patients. And we as the psychiatric consultant are relying upon that information to be really effective for us then to get a look at the individual patients. We're also serving that overall population. So in CoCM, we should not be doing a case review on every patient that starts care. That's a misuse of resources. We're really doing it, tailoring it for the patients who need it. Those who aren't improving, those who have a safety concern, those who maybe recently had an emergency room visit, those who aren't engaging well. It's those that are going to benefit from our psychiatric consultation in terms of impacting their treatment plan. Any patient could benefit from psychiatric consultation, but not every patient needs it. If they're doing really well, taking sertraline with their PCP, they've got a set care plan. We're not going to make any changes in recommendations. That's really not a great use of time and resources to then be providing a consultation on that, even if it, might be nice to have the comfy, cozy confirmation. So we want to be thinking about that. We're really here to serve an overall population health need, not just one individual patient's needs. We're doing that through that care manager, just like was shared, and the registry. So this is how we are gathering that information. That's the lens through which we're seeing the patient. And then at times, we may be looking at the electronic health record. That's especially important when you're doing a psychiatric case review, as well as talking with the primary care provider. In terms of factors important for effective implementation of collaborative care, there's this really nice study that was done by Whitebird et al. Back in 2014. And what they looked at were all of these diamond certified CoCM clinics. So basically all these clinics had criteria that showed they had high fidelity to collaborative care. But nonetheless, across all these different clinics, there were some very different outcomes. Some had much better improvements for patients. Some had much higher activation rates where patients got into care sooner. And so what this team did was they did structured interviews, and they identified 23 different factors that were associated with differences between various outcomes that were looked at. And so they looked at features like clinic infrastructure, interpersonal relationships, resources, and care processes. And what they saw was, in terms of remission rates at 6 months is one of the endpoints. So that's patients with depressive disorders who ended up meeting remission at 6 months. The factors that were most important were at the top, an engaged psychiatric consultant. Number 2, operating costs not seen as a barrier, and warm handoff between care managers and the PCP. So what we can see is that, both in the clinic, in the sense of when we're doing collaborative care, we can feel that piece when you have an engaged psychiatric consultant. It really helps with getting patients better. We also see it play out in the literature. So that's just something to keep in mind. In particular, engaged psychiatric consultation is strongly associated with patients actually getting better. Here's my next question. So is the psychiatric consultant role a good fit for all psychiatric professionals? Do you think, just having licensure is enough to be a good psychiatric consultant? What do people think?
I feel like theoretically many people would be like qualified, but I think it takes like liaisoning skills. I don't know, my own experience also has been that like learning how pediatricians practice and how that compares to how most we generally practice. So like adaptability and flexibility. And I think like being collaborative, not feeling like your way is the only right way to do things. So like those sort of skills are important.
Yes, they are. And some we learn in training as physicians and as psychiatric specialists, and some we don't. Some of these are called soft skills. It's very important to not overlook these. And I would say doing a lot of nationwide consultation and mentorship, this is the area that often is the hardest and the biggest cause of confusion. This idea that, oh, well, we have a psychiatrist. They're here, they're present. Well, it's more than that. And then what are those pieces? How can we break those down into tangible goals, into areas for improvement? So when we look at the collaborative care model, a key thing that can cause confusions is recognizing this is a primary care model, not a specialty care model. And so collaborative care, the goal is really to practice to the scope of primary care, but to the top of the scope. And so when we're providing psychiatric consultation, we are looking to the primary care provider as the subject matter expert in their scope, not us. That causes some humility to need to come in. So I may understand, let's say, how to do long-acting injectables, but I cannot assume one way or the other that my colleague has within their scope or outside of their scope the ability to do long-acting injectables. So I may ask that as part of consultation, as part of framing that, and asking with curiosity as opposed to judgment. That piece of, is this within your scope or is it not? Help me to understand where the top of your scope is. In some clinics, they will actually outline that as like criteria for what is within the scope and what is outside the scope of primary care. But if we don't know, it's important to ask the subject matter experts, which is our primary care providers that we're working with. The other thing is that we need to look at the way that we provide consultation fitting within the best practice recommendations for collaborative care, which may be what we're comfortable with versus not. So we as psychiatric consultants may feel much more comfortable having all the information at hand. But what is truly the minimum need to know? With this structured, iterative, we can consult multiple times and targeted approach, we have to adapt the way that we gather and use information compared to if we were gathering it all on our own and we had set appointments. So thinking about that really strategically and getting comfortable with that. It is not comfortable at first doing that sort of model, which is a totally different way than many of us are trained in traditional psychiatric training. And then the other thing is thinking about what are the kinds of things I'm typically consulted on and building your expertise and building your ability to engage with people on that. So for diagnostic clarification, commonly PCPs may want to know, how do I determine anxiety versus mania. So really knowing how to explain that to somebody. When we're doing this also, we're not talking down to people. We're talking at the same level. That's very important. So although we're the experts in these areas, we want to be encouraging that consultation. So that's a great question. Thanks so much for asking that. That's a common question that comes up. Normalizing these discussions, that comes through experience, and that also comes through taking a look at oneself and making sure that the way that we're providing recommendations, not just what we're providing recommendations for, is facilitating more consultation, not less. This comes down to also the care manager and PC dance. So a common kind of concern that I'll hear as a technical consultant is, care manager saying, I really have a problematic relationship with my psychiatric consultant. I don't know what to do about it. They're talking down to me, or I don't feel empowered. I have much lower licensure, or, I went to this training and the way that they're consulting is totally different than what, I was expecting. And then the psychiatric consultants, maybe sharing frustration with my care manager is not gathering the information that I'm needing. It's really frustrating to try and consult when I don't have all the information. I don't feel comfortable providing recommendations in primary care. So a lot of this stuff, there's individual factors, but it comes down to the alchemy of the relationship. So if one's not understanding the other, how are we communicating in ways that we have a shared goal, which ultimately is providing psychiatric consultation to the full scope of primary care? We are not doing a service if we are under hitting that, because then maybe patients are going to specialty care or needing direct evals who don't need that. But we're also not doing a service of saying PCPs need to be psychiatric level prescribers. So similarly with the care manager, we're helping to facilitate the information we're needing to gather and the lens through which we're seeing the population by sharing, here's the type of information that's helpful to gather. That's really good information. Can you get more on this? Or I don't need to know as much about that. And similarly, being receiving of feedback as the psychiatric consultant, what you're asking me to do, it's really hard to do in a 15-minute check-in, or I'm having difficulty knowing how to do this. Like, it's having that trustworthy relationship and that give and take, where ultimately we're working towards dancing to the same song and working together, even though we have different parts of the partnership. What characteristics are associated with an effective psychiatric consultant? So there's going to be individual and then team-based levels. So at the individual level, there's a lot of different publications that talk about this. There's not just one thing, but these are the things that come up over and over again. So they need to be a leader. And this doesn't mean a leader like saying, you're going to do this and you need to do this, but it's this idea of taking charge and taking ownership over the care plan and over making sure that we are contributing to that care plan that ultimately is held by the primary care provider. So if the PCP is saying, I don't feel comfortable with this patient, I really want to work on getting them into specialty care, how can I, as the psychiatric consultant, lead bridging care supports and make sure that we've got all the pieces at hand that's needed with the care manager relationship? They're also an educator. And this is done in kind of in the moment with curbside consultations, but also many psychiatric consultants will set up learning series or set up lunch and learns. That can be very helpful for being able to expand expertise and knowledge across your population. So if you're working with a pediatric team, what you're going to provide in terms of education is going to be different from if you're working with a perinatal population or primary care general adults. You're also a lifelong learner. It's really important that as a consultant, you're up to date on all the different new things that are out there. So making sure you're constantly approaching with curiosity, what are sort of the latest trends and the latest recommendations, evidence-based pieces coming out for common psychiatric and behavioral health conditions. Being friendly and extroverted also can be very helpful. If you're not approachable, it's going to be hard to get people to consult with you. So thinking about both in clinic as well as virtually, what are the ways that you can engage others to encourage future consultation? Also being available and interruptible. And so this is important also, not just on the psychiatric consultant level, but at the organizational level, making sure you have time available to do curbside consultations, making sure you have enough time to be able to provide your systematic case reviews. Also, having a risk understanding and tolerance. This doesn't mean that you have to approach things willy-nilly, like, oh, I don't have any concerns about risk, but it's understanding where your consultation lies on that risk spectrum, and that this is why we have medical malpractice insurance. So being able to provide those recommendations within the scope of your role, and being okay with people asking you like a curbside and providing recommendations without having to see the patient. You match also the level of consultation to the care need. So we're not going to do a direct eval for everybody just because we're comfortable with it. We're going to be able to provide that only if it's clinically needed. And then from the team-based approach, they're an effective communicator and a team player. Ultimately, it's not about the psychiatric consultant. It's about the care team, the patient-centered care plan. So we want to be able to make sure that we're really serving our purpose, not just ourselves in this role. Constructively responsive to the care team. So if things are not working, taking a look at being part of the solution, and reflecting on that advice and making that something that you're supporting. You know, thank you for sharing that feedback. That's really helpful to understand what would be more helpful, what areas of this are most difficult. They're intervening for patients who are not improving. This is particularly important for that original data point that I described of remission at 6 months. This idea of the engaged psychiatric consultant is especially important, that if patients are not getting better, you're going to be upping care recommendations, whether it's behavioral and or medication. And they empower and help team members to practice to the top of their scope. It's really not helpful as a psychiatric consultant to tell people, well, that's outside of your wheelhouse. We just need a psychiatrist. Find a way to say yes when you have to say no. So this would be the area that I would encourage for us to work on for psychiatric consultation. For this care need, I think we should bridge them to this or this. So finding ways, even when you're, having to draw a line or boundary, to empower and help the care team as opposed to disempower with your recommendations. In terms of pitfalls, common things that we see both in the literature as well as in clinical practice, a big one is care role confusions or discomfort. This is not the same as a traditional psychiatrist. And if you're not sure sort of where the consultation is needed to fit the care need or what your role is on the team, that can result in problematic recommendations and then also engagement with different team members. Unhelpful communication. So don't say those things of like, that was a dumb question, or that's not what I would do. That's not helpful. So making sure you're really looking at what are you providing recommendations on, why are you doing that, and how is this in service or not of the patient-centered care plan. Trust deficits. So we have psychiatric consultants who can work fully remotely. We have others that work in the clinic. The key thing is that there's a trustworthy relationship. You're dependable, you're reliable. The recommendations that you provide are good. So thinking about the multiple pieces that can play into that, both as the individual as well as the team-based. Ineffective use of time or other resources. We're having to care for a population, not just an individual patient. So if we're spending an entire 2-hour case review on one patient, that's not a good use of resources. However, some patients, they're going to need a little bit more and others are going to need less. Some patients need just a 5-minute case review. There's some patients that need up to 40 minutes. If you're on 54 different medications and you're needing to identify medications to taper, that's going to take a longer case review than somebody who's having engagement issues and maybe just needs a 5-minute review. And knowledge limitations, both for the role of the psychiatric consultant as well as related to how and what to recommend in terms of evidence-based recommendations for psychiatry. Systematic case review is a big part. So keep in mind, this is necessary to have collaborative care. If you're not doing systematic case review, you're not doing collaborative care. It's important both clinically as well as for billing reasons. These are structured, functional, recurring reviews. And some of the key things to keep in mind, the primary participants are going to be your behavioral health care manager and your psychiatric consultant. Other people can join. So sometimes PCPs can join, sometimes other care members, like if you have a behavioral health consultant or a care coordinator, they can join. But at minimum, this is the key participants you need. There's some organizations that set this up as a 1-for-1. That's really ideal, having one behavioral health care manager to one psychiatric consultant. There's others who will have a group approach. That can be done, but it takes a little bit more careful thought planning. But the key thing is there has to be these participants. And then the other thing is they have tools that help direct this review. And in particular, they need a registry. If you don't have a registry, you're not doing collaborative care. So this is building off of the registry. Although you may identify patients for review, there should be the ability for the psychiatric consultant to see the entire patient population. This is a structured format. So you're going to have typically a recurring process each time. And these are focused discussions on select patients. You're not reviewing every patient every time. You're not reviewing every patient altogether. Many of the studies show 50 to 60% of your population you're going to ultimately need case review on. It may go up or lower depending upon the severity and the needs of the population, but I can say clinically that plays out. All right, here's another question. What is the role of the psychiatric consultant in systematic case review?
I'm happy to be the person who talks if no one else has thoughts. I think like getting updates from the care manager about how the patient is doing, like reviewing the evidence-based measures to see like how their score is changing over time, and then to provide recommendations documented in the chart that the care manager can send back to the pediatrician. I don't know a question, but something I'd be curious your thoughts on, and I think it goes mostly with this question, is so as I said, we're like new to this. So we started last July. So we've learned a lot about pediatricians, and we've noticed like some of them are sort of like, yeah, whatever you guys recommend sounds good. And then some will like always do something slightly different than like what we like a totally fine. It's like, consider starting Prozac, and they're like, I'm going to start Zoloft. I'm like, cool. You know, and so, but then, for some of them, we've tried like, you could consider this or this if there's like, you know, because there's not usually like a one right thing. And so I was just curious in terms of like, do you think there's a general best practice of how to provide those, or is providing options a nice thing to do? Is that confusing? So I'd just be curious to hear thoughts on that.
Yes, you are not alone. And these we see in the pediatric population, in the college health population, in the perinatal population, in the adult population. It's the reality of working with people. So I would say some of this depends upon your primary care structure. So what is sort of the recommendations from your PCP champion? Are we in this clinic going to have a shared scope of care? So everybody has a different scope of practice. The nurse practitioner, FNP versus a, physician is going to have a different scope of practice, but scope of care can be defined in a care setting. So in some situations, your primary care champion can really define, we're going to want to make sure that everybody practices to X scope. So there's not that embattlement. Every provider is going to have a different way of doing things. And so often that is part of that dance. We have the care manager dance, but the PCP dance. And so I've got my certain PCPs that, for instance, will only curbside me through a behaviorist. I might recommend, this is a great opportunity to give me a call. What times work well for you? There's going to be situations that a menu of options works really great. So like you go to a restaurant, you're not going to order everything on the menu. That's better if you're having a situation where maybe there's an entree, an appetizer, and a dessert. Like you're going to have multiple steps. For complex patients, that works really well to have that sort of roadmap approach. I have some PCPs, though, that gets really overwhelming for them. So I know who those PCPs are. And so I will break that down a little bit. And I may keep in the registry, here's some thoughts for next time so that I've got those notes. So you tailor it to what's the minimum need to know for this question. And for a complex care question, it's going to need a more complex response. The literature talks about this iterative approach where first you're maybe going to make a little recommendation to Zoloft, and then you're going to make a little recommendation in here. And the reality is when you care for patients with more than one medical and psychiatric comorbidity, that does not work. So this is part of that adaptation of sort of what are best practices to what's the reality of practicing in real life. Your approach is spot on. This idea of like, some I'm seeing need this, some I'm seeing need that. It's because of the complexity of the case and also the needs for the PCP, and you're going to have to be adaptable for that, just like what you're doing. So in terms of the basics, this article by Dr. Bauer, I highly recommend. It's great. It's best practices for systematic case review. I would say that this is a great foundation to build off of, but also goes for more of that kind of like first or second episode major depression, needs to be adapted for a more complex population, which is what comes in here. So the AIMS Center has this really nice spectrum of the amount of patients on a caseload that you have based upon complexity as well as uninsured, SDOH problems. So if you look, fewer patients are recommended to be on the caseload for very complex conditions and for, limited resources. So similarly, you need to take that into consideration when you're thinking about the number of patients you're going to review. Some of those patients might need more recommendations related to SDOH. Some patients may need more recommendations and more review if they're highly complex. From Dr. Bauer's article, here's sort of the recommendations for amount of time based upon caseload size, but I would really challenge, look at it also alongside of your complexity. In my care system, we do 2 hours weekly systematic case review for a target population of 75. We start out with 2 hours for every care manager because we're going to be doing more training. By the time they're fully up and trained, all of that time, or as much of that time as possible, is going to be billable caseload time. In terms of getting organized for SCR, keep in mind you have to have a way of communicating either over phone or ideally over virtual or in person with the care manager. You're going to need to have open your electronic health record. There's some people who, they gather all that information through the care manager. I would really encourage, as a psychiatric consultant, having the ability to lay eyes on your electronic health record. That's a much better use of time than having your care manager write down hyperthyroidism, obstructive sleep apnea on CPAP. You can see all of that very easily as a psychiatric consultant. So that's a time saver, and it really helps also with entering notes in. And then, of course, you're going to both have open the registry. So those are all going to be the things you're going to share. The care manager, and then also time. So both should be kind of keeping track of time in minutes. That's helpful to share in terms of responsibility in case one gets distracted. The care manager should be prepared to document care team collaboration. So sometimes we may not have all the information needed for review this week. Maybe we're going to push it off to next week after the care manager gathers X, Y, and Z concerns. So that could be a really nice care team collaboration note to document as opposed to a full case review. Or maybe they're just updating you that Dr. Smith did not follow the case recommendation. So maybe they're going to say updated CP related to the outcome from primary care visit. That can document that piece. They also are really good at maintaining the agenda, which is sometimes done in the registry, but other times, because of all the different things you're doing, you might need to have that separate. The psychiatric consultant should be prepared to document your case reviews, whether short or long. That's often helpful to have a basic template that you're using. Also, I really encourage them to be the ones to look up the medical details in the electronic health record, both for accuracy as well as timeliness. In terms of systematic case review, so if we take a 1 to 2 hour duration, as is recommended by Dr. Bauer and is generally best practices, you're going to have some time at the beginning and the end for a brief check-in. That would be like clinic updates. When are you going to be having time off? Are there any like basic questions kind of coming up related to processes? And then wrap up, which would be like celebrating successes, making sure you've got all your to-dos just right. But the vast majority of this time should be captured billable time through case reviews. Your billable time is that time discussing with the care manager. They should be documented in real time. That is a skill that takes some work and practice. It took me about a year to get really solid at being able to hear what the care manager was saying, concurrently document, and then have it all done by the time we were done with the discussion. Some psychiatrists or psychiatric consultants will like to hear that in terms of give me just a rundown of a brief case. Others, they might want to kind of dissect it, because if there's like differences in how you're doing a case review, it might be helpful to say, what's their diagnosis in CoCM? What's their PHQ-9 most recent? What's their initial, it can be helpful to do one of those two ways, and there's advantages and disadvantages to both. With the brief check-in, you're setting an agenda and doing those clinic updates. And then for the targeted case reviews, you're systematically reviewing in the registry different patients for the key questions. Start with the most clinically pressing ones, the ones that you cannot leave this case review without completing, and leave the reviews for the bottom that you could do okay putting off. These can be clinical questions and clinical concerns. Clinical concerns being like, let's say there's a safety issue or they had an emergency room visit. A lot of the time is going to be spent doing those who aren't improving, engagement difficulties, readiness for graduation, and then other clinical or administrative needs. So there might be some insurance companies that say you need a case review every month for all of the patients. That's not best practice recommendations, but in like New York State, for instance, that's a Medicare requirement. So we do a brief, placeholder note saying patient was reviewed for Medicare billing requirements, no psychiatric clinical indications for review. And then that end, you're celebrating successes, confirming to-dos, and making sure you know when the next SDR is. So the way that you set up the care manager presentation can vary each time, but this is what I use for my approach, with the minimum need to know that I have to know for every case. So one is patient identifiers. The next is the reason for the review. It's really helpful to know, why are we reviewing this person, to frame how much information we're going to need and target the amount of review to that. What if they, how have they been doing in CoCM, broad strokes? So why were they recommended? How well are they doing with check-ins? Are they on any medications? Were there any medication changes? When were they last seen by the PCP, and when are they next going to be seen? These are very helpful for being able to kind of frame, what am I going to recommend now, and maybe what am I going to hold off for? Depression, especially most recent as well as initial, to see the change. Same for anxiety. And then there's severe and safety. So helpful to look at the PHQ-9 item 9, and then based upon your safety procedures, you might do the CSSRS if the score is greater than 0, or other clinical markers of safety. You might use the ASK in the pediatric population. Asking about substance use each time is very helpful. And then current or history of mania, current or history of psychosis is helpful to include. Not every patient is going to need to have review of all their medications or previous hospitalizations. Not every patient is going to need to have psychosocial components added in. This is sort of the bare minimum of what you would need to know for most, for all the basic ones, including engagement difficulties, including safety concerns. This is Dr. Bauer's recommendations for a case template. I would say it's important as a psychiatric consultant to take those recommendations, but then adapt them for what's needed. Every case review should include the disclaimer related to what you did and what you did not do. Notably, you need to correlate these with clinically relevant information. You did not see the patient. And then many of the case reviews, it's best to put at the top what the recommendations are. PCPs are not going to want to scroll to the bottom, even for a short review. So that would be, one of the things, the major changes I made for this one. And then you want to have in the summary, why are you consulting, your diagnoses, status in CoCM, anticipated next care steps, common and severe markers, common rule outs, and then big picture, like what's been trialed in the past if you're looking at prior medications. So take home points. Keep in mind the psychiatric consultant is a vital part of the collaborative care team. The psychiatric consultant prioritizes supports for the care needs of an overall population, not so much the individual patient like a traditional psychiatrist. The PC role is not a good fit for everyone. Same as not every psychiatrist is necessarily going to want to be an inpatient doc. Not every psychiatrist is going to be a best fit for an outpatient care setting. Goodness of fit also is not a static thing. It's dynamic. It can improve with training and experience, mentorship. It's very important to be keeping that in mind, especially when there's problems that are occurring in the care relationship with your psychiatric consultant. The PC engages the care team through activities primarily facilitated through the care manager, and that's true both clinically as well as for billing and coding purposes. And during SCR, it's really important to strike a balance between those individual patient needs and the population health needs. You're going to use this structured framework, but you need to have flexibility to adapt how much you're asking and gathering for patients based upon the clinical question at hand. And the PC and BHCM relationship is especially important for CoCM success. All right. Did that answer the questions you had also for SCR?
Yeah, I had a quick, I guess I was curious. So in your 2 hours, like how many patients in general then would you talk through? How many minutes per patient on average? Obviously, there are like, I'm sure some that are more complex, some that are less, but just wondering like what the target should be.
It should always be more than 5. Okay. But I can say some case reviews, I might review more than 10, and others I might review 6.
Okay.
It's about who's needing it. And so some weeks, if I have 3 back-to-back patients that are just really complex, I might say, all right, where's our diddly little reviews to pack in there? I also look at, let's say somebody's following up with primary care provider next week versus at the end of the month. We might time that review a little bit closer, and maybe we have a whole bunch of reviews at that time. So I always give caution for saying you need to every time do this. That works really great if you have a very homogeneous population. Everybody's first episode major depression. Yeah, I could do all day long 5-minute reviews. But the reality is that, clinical questions are going to take probably 15 minutes, upwards of 30 minutes. Engagement notes are going to take about 5. Safety reviews are going to take between 5 and 10, depending upon, are they going to need a safety flag or are they not? For graduation, don't review everybody. If they're RPP straightforward plan, that's cool. But if they need help with an RPP plan, you might do a 3 to 5 minute review for them. My Medicare notes are 2 minutes at most, 1 minute, for most of them. So be thinking about the buckets, and then be thinking about, in that 2-hour review time, how am I going to meet the overall needs for that overall population? That's where that AIM Center one about sort of the level of the number of patients you have on the case review is also helpful to think about, or the number of patients you have in a caseload is also helpful for you to think about in terms of case review. How much time is it going to take? For adolescent population, those reviews often took less time than it does for my adults who are like 60 on so many different meds, lots of medical comorbidities.
Yeah.
So that's one of the advantages. But what took a lot of time for adolescents is all of the care coordination logistical stuff. Like, this person has safety concerns. Is there a CPS report concern? Do we need to activate the safety plan? They don't want to talk to mom about this, but do we need to? Like, those are some of the things that are going to take a little bit longer. I would say it took about 1.5 years to get really, really efficient with those. And it took me longer when I didn't know what I was doing. So if I was like, oh, I just don't know what to do with this, it's going to take longer. It gets faster with time. That next time you see that same person and you've figured out what to do, it's going to take like half the time. So also try to have your organization work with you with some flexibility on, I'm trying to be a good steward of resources. I'm trying to be very careful with this. AIM Center says 3 hours total, typically for psychiatric consultants with prep, ad hoc. In my care system, we do 4 because I'm also present in team meetings. So kind of be thinking about that, what's realistic for billing and coding needs, and then also what's realistic for clinical delivery. It's going to be different for each care system.
Okay.
Does that kind of give a framework?
Yeah, no, that's really helpful. I think the other thing I was curious about, because we sometimes have this where like, should we do a case review? And then we like look briefly and we're like, actually, we don't know this yet. So let's wait. But we have
Care team collaboration note.
Yeah. So, and we have not been doing that. We've just, so it's been like, I guess that's lost time. So that's really helpful. And that would still be then billable by
Still capture that time.
Okay. So that's helpful. That's like really easy thing that we should do. So, and then you just don't route it, obviously. There's no like, the recommendation that I might write would just be like, the BHCM will collect this information and will then review. Okay.
You can write it, or the care manager can write that note.
Okay,
I typically bundle that under the monthly. So if you have one long monthly note the care manager is doing, just have it go under there. The only things I put as a separate note are things that I want my PCPs to know. If it's just recommendations also to the care manager, we put that under the monthly note. Because what I've noticed is if you have too many case notes, PCP won't read, they're gonna have trouble reading it anyways.
Yeah.
What's capture every minute of that though. So if you spend 6 minutes trying to figure out you don't need to do a case review that week, still capture that time in a care team collaboration note. Identified this patient needing case review. They've got PCP visit coming up in 2 weeks. BHCM and CP discussed need to gather X, Y, and Z. That's only 3 sentences, but that might be a 7-minute time. So capture all that time. Capture every minute. Anytime you're discussing a patient, capture that time. The only time that would not be captured would be administrative things. You're like going through, your scheduling, or let's say it's truly just for edification purposes for the care manager. Like, can you walk me through, Dr. Jacoby, how to do an ADHD assessment? And it's nothing to do with a specific patient, or it takes a lot of time that you can't really justify. That's where in the beginning, when you're working with the care manager, there might be less billable time, but by the time you're seasoned and have that dance down, like 48 minutes of the hour at minimum, like 55 minutes of the hour, like everything, you should capture everything billable that you can. You should try to get exactly 2 out of 2 hours billable is sort of the difficult to reach, but target.
Okay, that's really helpful. Thank you.
Yep, great questions. Any other questions from the group? Things that you've noticed going well, things that are really problematic, things that didn't make sense from that discussion.
I'm with Selena. My role is evaluation, and I'm from like a more community mental health center with like assertive community treatment and how they did case reviews. And so I just want to say that all this information was like very helpful for getting like grounded in sort of the practical and logistical aspects of case review within the collaborative care setting. So appreciate that.
Great, that is the goal. It's wonderful to talk theory, in the academic classroom setting, but we really need to know practically how to do this. And that ultimately is, I would say, one of the biggest barriers for implementation, taking like best practice recommendations and making them fit with the very diverse realities of where we're working.
Any other questions, Sarah, Katie, Rebecca?
No, I was just going to say, we're in the process of planning and, getting this started at our institution. And so this is a vital piece and provided a lot of information. So I appreciate it. Thank you so much for your time.
Absolutely. As you're getting started, sometimes it's really hard to find a good fit for this role. So if you find somebody who has like the basic credentials, but then has some of the soft skills, maybe needs additional training, getting them connected with MHA, a Collaborative Family Healthcare Association is really helpful also for like mentorship training. So, don't feel disheartened if it's also, as you're getting started, hard to find somebody who's like right from the get-go a perfect fit for this. If you find somebody who's got some of those soft skills and got curiosity and just maybe need some training, there's a lot of other pieces out there for support. So I don't know if that's kind of what you've been experiencing, but I can say that's something I've experienced when I worked in Texas, when I worked in college health, and now in the community.
Yeah, and we have a psychiatrist that, has kind of been part of this planning process. And I was like, I'm going to send him this recording because I think it would be helpful for him to see this as well.
Absolutely. Yep. And if there's any questions or concerns, other like spaces to go, there's the CoCM special interest group through CFHA. Look for, other networks. There's a collaborative care psychiatrist group on Facebook. There's a lot of different spaces to be gathering information, collaborating, and receiving mentorship. So strongly encourage that, especially if somebody's new to the role, even if they've got all the basic building blocks to be successful.
Perfect. Thank you so much.
You're welcome.
All right, I think we're good to go. Dr. Sadari, thank you so much again for your time. Or would you be able to share your slides with us?
Yeah, absolutely. I'll send them to you.
All right, and we'll distribute that to everybody in our group. Well, thank you so much for your time, everyone. That's the end of our session. Have a good day.
Thank you.